Alright, we are continuing with the skeletal system, talking about the appendicular skeleton this time. So just like the axial skeleton video, I'm not going to go into a ton of detail here because we've covered a lot of these bones and the features on them already in lab, so we don't need to redo that in lecture. But we'll do a quick kind of overview again, refresher type of thing, and then talk about that embryonic development at the end. So again, we're going to look at the bones in the appendicular skeleton, touch on the pelvis and stuff like that, and focus most of our efforts on that embryonic formation. So again, that appendicular skeleton is the limbs, so shoulders, hips, arms, legs, hands, and feet are all part of that appendicular skeleton. So pectoral girdle, this is the official anatomical term for the shoulder. So this is the scapula and clavicle that are forming the pectoral girdle and attaching to that humerus to form that final shoulder joint. So lots of ligaments and stuff holding all of these bones together, that clavicle and scapula, as well as attaching out to that humerus. So clavicle, we've covered that already, as well as the scapula. Again, bones of the upper limb, so this is going to have 30 different bones, making composed of the arm, forearm, and hand. So the arm is just the humerus, forearm is the radius and ulna, and then the hand includes the carpal bones, and then metacarpals and phalanges of the fingers. All right, and so again, I don't want to go into a ton of detail here, but we've got our humerus. We can see a little bit of how it articulates with the radius and ulna down here to form that elbow joint. That radius and ulna shown here, lots of connective tissue in between them, and then these do cross over each other when you're standing naturally, so not in anatomical position with the palms facing forward, but standing naturally, these two bones are actually crossed over each other. And then we've got the wrist and hand bones. Again, carpals are making up the wrist, and then the metacarpals make up the palm of the hand, and then phalanges are the fingers. So quickly, carpal tunnel syndrome, this can develop due to a variety of reasons depending on injuries and repetitive motions from jobs and stuff like that. And so we can see these carpal bones down here. And then sitting over that, we've got some tendons from a bunch of muscles that run up the forearm and into the hand, and then a really prominent nerve coming through here. There are more nerves that come through here, but we're focused mostly on this one right here. And then we've got this tendon sheath here, the flexor retinaculum. We'll cover that again with the muscles unit, but that kind of encapsulates all of those tendons and nerves forming the carpal tunnel. And so inflammation in this area of these muscle tendons and the flexor retinaculum can put a lot of pressure on this nerve, causing a lot of pain, numbness, and tingling in the wrist area and parts of the hand because that nerve is being compressed, and so signals aren't getting through to the hand properly. And so that's how we get carpal tunnel syndrome. There are surgeries that can correct this in many cases, but not always, and sometimes it's just a little bit of rest and relaxation that's needed to kind of get that inflammation down. Alright, and then our lower limb, the pelvic girdle and pelvis. So this is the hip joint. The hips are made out of those coxal bones to attach the lower limbs, and the hip bones are joined to the axial skeleton through the sacrum. Alright, so that sacrum is part of the axial skeleton, and that's how we fuse our lower portion of the body to that axial skeleton. Pelvis is made out of those two coxal bones, the sacrum and coccyx. Alright, so that's what we're seeing here. So that sacrum right in here, again, is part of the axial skeleton and not the appendicular skeleton. Alright, we've got our coxal bones here. We've got a lot of ligaments in the pelvis holding things together. So that joint between the sacrum and coxal bones is called the sacroiliac joint, or SI joint. And so we've got that connection there, and then we've got a lot of ligaments that are going to help hold that SI joint together, as well as connecting in other portions of these coxal bones, as you can see. Alright, so you should again know some differences between stereotypically male and stereotypically female pelvises. This isn't a hard and fast rule. There's actually a rating system used to sex pelvises of found skeletons, and they range anywhere between 1 and 5. I don't remember off the top of my head which end is which, but I think a rating of 1 would be definitely male, and a rating of 5 would be definitely female. And then you've kind of got some variation in the middle there. So like a 2 would be most likely male, and a 4 would be most likely female, and then that 3 right in the middle is inconclusive, and there's no way to accurately sex that pelvis just on appearance alone. So this is not a hard and fast rule in the real world. Mother Nature does not do binaries, it does spectrums, all right? So a lot of times the textbooks and material and stuff that we use in a class like this are going to make it really, really obvious, but that's not always going to be true in real life. All right, so female pelvis tends to have lighter and thinner bones. The inlet is going to be more round or oval shaped. It's going to be shorter and wider for that pelvic cavity. The subpubic angle is going to be more than 80 degrees. It's going to be more of a U shape, and then that outlet again is larger and rounded. And this is an evolutionary adaptation for childbirth. Male pelvis, at least a stereotypically or definitely male pelvis, their bones are going to be thicker and heavier. That inlet is more heart-shaped than round or oval-shaped. The pelvic cavity is narrower and longer. That subpubic angle is less than 70 degrees, so it's usually more of a V shape. And then the pelvic outlet is much, much smaller because they do not need that adaptation for childbirth. All right, so just kind of see that in action. So we've got that subpubic angle, more of a U shape versus more of a V shape, and then that inlet and the entire overall pelvis is going to look a little bit different. And then the rest of the bones of the lower limb, we've got the thigh made up of the femur, the forearm or foreleg is the patella, tibia, and fibula, and then the foot is the tarsal bones, metatarsals, and phalanges of the toes. So again, I'm not going to go into a lot of detail here since we've covered this in lab, but we've got the femur up in the thigh area, fibula and tibia down there in the lower leg, and then bones of the foot again. And we will wrap up talking about embryonic development of the appendicular skeleton. So we form what are called limb buds, so just kind of that cartilage template for developing the bones of the arms and legs. These are going to start to appear around the 4th week of development, and all of the bones of the limbs, so arms and legs, are going to develop via endochondral ossification, except for the clavicle, which develops via that intramembranous ossification. And so that endochondral ossification, if you remember, has primary and secondary ossification centers. Those primary centers are going to be towards the center, that middle portion of those long bones, to form that medullary cavity mostly. And then the secondary ossification centers appear at the ends, the proximal and distal ends of those bones. So we see those primary ossification centers appearing around week 12 of development. So while those limb buds, that initial cartilage template, forms around week 4, it takes a while for those primary ossification centers to appear, quite a while later, and then the secondary ossification centers don't actually start until after birth, generally speaking. It can be a little bit before birth, but usually not much before that particular point in time. All right, and this helps keep babies a little bit smaller. We don't want to start solidifying the ends of those bones yet. We need them to grow in length first before we start solidifying the proximal and distal ends of the bones, but we do want to have a little bit of support there from those primary ossification centers. And that's it for the appendicular skeleton.